on the screen. They'll pop up. I think they're going to be on Teams.
So everybody else is going to be on?
Yeah, so Hunter, Sandra, and
I can help out and I am training
Because you should have great.
I'm training them to set traps.
yes, absolutely. Good, yourself?
Second, yeah, now it's all in place. So, I mean, so most of what we have is contingency management. Yeah, so.
Check my calendar slowly.
Yeah, that we're only getting a year. So, I mean,
All right, thank you.
51 years, but we probably do that for years.
Yep. Okay. There we go.
We don't need them to spray. There's no.
Why? Because they're.
We had to spray. Herbicide early in the season. So, we put the money in.
Oh, gee. Oh, I didn't know if they were on there.
They're on. Actually, they can hear us. So you just can't see them, but they're there. All right.
Good evening, ladies and gentlemen. I'd like to call this meeting of the Mohave County Health Board to order. It's not March the 9th, 5:30 p.m. or 5:32, a little bit late getting started here. I had some good conversation going on. So we'll start this evening with the Pledge of Allegiance. If you'd please all join me.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Thank you very much. We'll begin now with the call to the public. Do we have anyone that wishes to address the board from the public? Okay. Seeing none, Denise, would you do a roll call, please?
Certainly. Okay. Hunter Adams, are you on?
Yes, I'm here. Can you hear
Thanks,
me okay?
Hunter. Yes, we can hear you. Thank you.
Great, thank you.
And then we have Curtis Manley, Nancy Mongeau,
Here?
Jean Bishop.
Here.
Do we have, Cal, did I call you yet?
No, I'm here though.
Okay, Cal. Wow. Sorry, these end of the day meetings sometimes, I tell you. Sheesh. All right, Sandra Thomas,
Yes, I'm here.
Marley Lucas. Marley, are you
Yes,
on the
I'm
line?
Yes, I'm.
Great, thank you. And Allison Fair. Okay. So Allison, are you there? Okay, all right. So it looks like we do not have Allison with us today.
Okay, but we do have a quorum, so we will go on with the business to come before the board. The first item is the discussion of possible action, the approval of the September and December meeting minutes. Looking for a motion.
So moved.
And we have a motion. It's been seconded. All those in favor indicate by saying aye.
Aye.
Those opposed, say nay. Okay. Motion passes. We now will have a discussion and take possible action on the telemedicine presentation.
Okay. Members of the board, we have a presentation by the Elizabeth Krapinski. I don't want to get her name incorrect here. And she is with Emory University, and she's going to be doing this presentation as part of our commitment to you to talk about what telemedicine is in our community and some opportunities. I need to make sure that she is on the line because I said 5:45 because I wasn't sure about how long it would take us, and I just want to make sure that they're on the line. So, Elizabeth, are you on the line yet? If not, we can probably proceed with the Arizona Health Zone presentation, the AZHC, and then I'll keep an eye on their, listen for the U of A folks. And when they come on, we'll transition when Sarah's over.
Perfect. So we'll skip down to item number 3.
Great.
This will be a discussion of possible action, reference the AZHC presentation. And we have our presenter heading to the podium. Good evening.
Okay. So let's see. All right, fingers crossed I can actually work this. All right, hi everyone, my name's Sarah Hancock. Thank you for allowing me to speak today. I'm the program coordinator for a program out of the health department called Arizona Health Zone. Basically, in a nutshell, what our program aims to do is we aim to improve community health through a focus on policy, systems, and environmental work that focus on either nutrition or physical activity. So roughly speaking, if it's related to either nutrition or physical activity, it could very well fall within our wheelhouse. This can range from anything from advocating for walking and biking paths all the way to gardening or teaching in schools about nutrition and physical activity. Lots of different kind of activities that we're allowed to do as long as they're related to one of those two topics. Another goal that we have for our program is to improve the likelihood that people who are eligible for SNAP, and in this case, SNAP is an acronym that stands for the Supplemental Nutrition Assistance Program. It used to be called food stamps. It's called SNAP today. We're trying to work with that target population to ensure that they can make healthy food choices and also be physically active while recognizing that that can be uniquely challenging for that group. So we take strides to make sure that that audience, SNAP eligible folks, are our primary people that we serve. We try to make sure that they represent at least 50% of any of the sites or populations that we work with in order to make sure that they are receiving the benefits that we provide in the education. In the bottom right-hand corner of the slide, we have taken from our policy and procedure manual kind of the breakdown in a visual of what our program's all about. So we're founded on a basis of health equity, trauma-aware principles, and community engagement. The bottom two, community engagement and trauma-aware principles, are kind of new focuses for us for this 5-year grant cycle, which is exciting to see. We split our activities into one of those 3 groups, active living, childhood, or food systems, and then we have that goal statement there on the top again. So when we talk about funding, we have a flow chart here that kind of describes our funding, which I think is slightly unique for this program. So we are affiliated with SNAP. We're called SNAP Education. Arizona Health Zone is just kind of the Arizona title of that for us. So if you ever hear SNAP Education or SNAP Ed, that's referring to us, and then Arizona Health Zone is just the Arizona specific title for us. So SNAP has its own pool of money, and as part of that, they fund education efforts, including this program. It goes from the USDA down to DES, the Arizona Department of Economic Security, down to ADHS, who is our actual implementing agency who we work with the majority of the time, and then down to us. We're considered the local implementing agency, and we're the one who implements the program here in our communities. So when we think about our work, we try to make sure that we're focusing on not only doing direct education and working with folks one-on-one, talking about the benefits of a healthy lifestyle, healthy nutrition, physical activity, and all of those things, but also incorporating kind of a wider lens to focus on policy, systems, and environmental changes. Basically, it's keeping in mind that even though someone may have the knowledge and the desire to be making healthy choices related to nutrition and physical activity, if they don't live in an environment that makes that choice easy or applicable to them, then they're not going to be able to put into practice the education that we give them. So we still do plenty of direct education work down at the bottom of this kind of pyramid here in the strengthening individual knowledge and skills. That's still a big part of what we do, but we also try to work upstream a little bit and focus on making sure that the environment in which our participants live makes it possible for them to implement the education that we're working with them to provide. So that could include working on different policies that support health, whether it's nutrition or physical activity, working with bigger organizations to change the actual practices that they have that could support health, working with coalitions and networks to make sure that we're expanding our reach and maximizing our resources, and educating providers that might be working with those groups every single day that might be able to implement some of the education that we're talking about as it relates to nutrition and physical activity. Some examples of partners that we've worked with, this is by no means an extensive list, but this is just a couple of ones we've been working with either in the past or recently. In the active living category, that encompasses sort of like physical activity and making sure that the environment is safe and appropriate for people to be active in. We've started a walking group that took a hiatus because of COVID, but that was one of the groups that we worked with. We work with parks and recreation departments on some of the events that they do, or assessing parks to see if there are any improvements that could be made. We work with city governments, usually in like their transportation department, and making sure that the plans that they have for that are conducive to walking, biking, active modes of transportation. For the childhood section, we work with the WIC Clinic, which stands for Women, Infants, and Children. We also work with Head Starts and daycares to make sure that those early learning centers are as healthy of an environment as possible for young children to build healthy habits right from the start. We also work with schools. They're one of our major partners that we do lots of different things with, all the way from policy to direct education. After school programs like the Boys and Girls Club. And then for food systems, we work with gardens. That could be community gardens like Dig It Gardens here in Kingman, or it could be individual gardens working on education and telling folks how to start a garden from scratch. Farmers here in the area, libraries, and also the senior centers are one of our partners in that area. So here's some examples of Zen, my coworker, and I out in the field providing direct education and just some of the day-to-day work that we do. We have a picture of us doing a food demonstration and class at the Boys and Girls Club on the left. That day we all made fruit skewers together and talked about fruit as one of the healthy food groups. And then the middle picture is us at Dig It Gardens, talking with the kids about fruits also. I promise we do sometimes talk about vegetables. These pictures just all happen to be fruits. We love vegetables as well, I promise. And then on the right, we just have some of our educational material that we came up with to teach at Boys and Girls Club, talking about the different food groups. That's pretty much it in a nutshell. If anyone has any specific questions, comments, or anything they'd like to know further, I'd be happy to take those questions at this time.
Okay, thank you very much. That was a good presentation.
Thank you.
Any of the members have any questions or comments they'd like to make?
I have a question, if I may. Thank you so much for the presentation, and being from Colorado City, you know, an extremely rural community without access
do you have your
to
microphone
many
on?
walking
There's a little
paths,
button there.
public courts, tennis courts, basketball courts,
Okay.
rec center,
Now,
swimming pool.
test.
You know, there's
Okay, Dr. Manley, go ahead.
Hunter, I think I hear you in the background, and I think I missed the direction of your question. I'm sorry.
Oh, I apologize. Can you hear me okay now?
Oh, much better. Thank you very much.
Okay, I'm
I'll speak up a little bit. Thank you, and I apologize if I cut anyone off over there with technological difficulties. Thank you so much for the presentation.
Absolutely.
Being in a rural community without access to a lot of active lifestyles for youth, adolescents, and adults, I think the work that you're doing is incredible. My question is, are there any ideas for like county-wide initiatives, or was this presentation more just educational to try to spread awareness, to try to reach some of the different parts of the county?
Excuse me, could I interrupt? Could the speaker that's speaking virtually identify yourself, please, so that we know who's talking?
Yes, this is Hunter Adams. Thank you.
Oh, okay, Hunter. I just heard this little voice appear and didn't know where it came from. So thank you, and go ahead.
Yeah, absolutely, Hunter. I think that the intent of this presentation was just kind of to introduce the program to a different group of individuals just to draw some focus to it. But I think your point of using this as a platform to build collaboration on a wider scope, maybe something countywide, it is something that we're definitely interested in, especially because we know that working collaboratively with other groups who are interested in doing this as well is a great way to maximize resources and kind of make sure that people aren't duplicating the same work and making sure that we're all moving in the same direction for the best common goal. If there was more county interest, and especially you, Hunter, if there was other people that were interested in forming like an active living sort of coalition or something like that, then HealthZone would definitely be on board with that as well.
Excellent, thank you.
Absolutely.
Okay,
Other questions?
Dr. Manley?
I just wanted to speak with you afterwards. We can talk about how I can get education to my patients in my practice.
Absolutely.
Okay, thank you.
Okay, thank you.
Anybody else?
Anyone else? Is there,
Supervisor Bishop, if we could, in Lake Havasu City, we have a farmer's market. It might be a good opportunity to run an education program at the farmer's market before it starts or on a Saturday morning. And I can help coordinate people if that would work for you. But we'd love to have some more education in Lake Havasu City.
Absolutely. Thank you very much.
Yeah,
I
thank you.
appreciate that.
okay, and this may be an opportunity to provide education in our new wellness van whenever that comes and we get it up and running. So I look forward to that being available through that program as well.
Definitely.
Anyone else on the phone? Going once, going twice. All right, well, thank you so much for the presentation, and good job.
Thank you, everyone.
Okay, so is the telemedicine presentation perhaps ready now?
I hope so. I was just, there we go.
There,
Yes,
wonderful.
all right, perfect, wonderful. If you could, please introduce yourself to the Board of Health here and then go ahead and get started on your presentation. We really appreciate you being here.
Excellent. So can you see my slides there?
Yes. I see you. I don't know if the slides are,
I shared my screen.
We can see the slides. I can see the slides.
Okay.
Yes, I can see the slides.
Excellent. So I'm Elizabeth Kapinski. I am the Associate Director of Evaluation for the Arizona Telemedicine Program and the Director of the Southwest Telehealth Resource Center, which is a subsidiary of the Arizona Telemedicine Program. So what I wanted to talk a little bit, just give an overview of telehealth and sort of what's been happening in that arena over the past, say, two years. We all know that the use of telehealth has dramatically grown since the pandemic started. And as this graph shows, there was a huge increase last March, April timeframe when everything really just kind of hit all of a sudden. And it dropped a little bit, but it really stabilized at about 38 times higher than what it had been used pre-pandemic levels. So I think people really saw a lot of benefit in telehealth. Now, this is another map showing where it was used and to what levels. And as you can see, Arizona was one of the top users of telehealth in the country. And I think there's a variety of reasons for that. One being that it's been used for almost 30 years, well over if you go back to, for example, a very early program called StarPath that took place and was now the automotive nation. But Arizona has always been one of the leaders in the field. And as I'll talk about later, a lot of that has to do with our government and our state government and how amenable they are to telehealth. But it really has been a really lifesaver for a number of our communities, and especially during COVID. Now, the big question is that people have is, well, what works and what doesn't work? From my perspective, probably every clinical specialty has something that works and is appropriate and well suited for use via telemedicine. There are certain things you cannot, probably should not do, but there are others that are very well suited for telemedicine. That ranges everything from just sending images like radiology, cardiac images, dermatology, ophthalmology, to capturing images and sending them to providers, to listening to heart sounds at one site and transmitting those by use of an electronic stethoscope, for example, for cardiac and pulmonary signals, to telemental and telebehavioral health, which is huge, and very well suited to telemedicine, to group therapy, towards support groups, to dealing with the patients in their homes and bringing telecare into the home so the patients don't have to leave home. So, like I said, I think practically every clinical specialty has something that can be done via telemedicine. That includes surgery, that includes dentistry, that includes a lot of specialties, PT and OT, that you were typically think of, how on earth could I do that? But it is being done, and it's being done quite effectively in many areas. Now, how do you decide what to do with telemedicine, when to use it and when not? The first thing really is to figure out what's needed in your community. Now, the pandemic obviously put a lot of restrictions on people's ability to come into a clinic, and the providers couldn't get to clinics and hospitals either. But as we emerge from that and decide, well, how do we continue to, or even start to adopt more telemedicine afterwards, you really have to look at your patient data and your current outcomes. You know, what's happening without telemedicine or even with, and how do we expand it? So looking at, for example, the number of diabetics, or the number of folks in your community diagnosed with late-stage diabetic retinopathy. Whatever the need may be, look for your community and for your hospital enterprise system. You have to look at local physician gaps. For example, do you not have neurologists? Or maybe you have neurologists, but there's one neurologist in your community, and gosh, every now and then that neurologist would like to take an evening or a weekend off, or go away for a week on vacation. What services are your patients having to travel to or be transported for? For example, if they're out in a rural community and you have to, go to get expert care, do you have to travel to Tucson or to Phoenix to get someone in the proper clinical specialty to be able to perform the surgery or to get, for example, proton therapy for your cancer? You also have to figure out how to tie it into your practice. Telemedicine is not something different. It's not a new clinical specialty. It is simply another way of providing care utilizing telecommunications technologies. And so you've really got to figure out how does it complement or expand your clinical offerings, or can it substitute when providers are unavailable? What specialty services would benefit most from it? What hours will it be offered? Or, for example, what a lot of places are looking at now is if they did start to use it during COVID and they're seeing the benefits of it, is it perhaps, well, every Tuesday we're going to offer telemedicine visits? Or is it every afternoon or every other afternoon? So you have to figure out how to work that into your existing workflow. What are the personnel requirements? How does that affect your front office staff? How does it affect your nursing staff, your APPs? All the variety of people that are involved in patient care. It doesn't just affect that single provider who's going to interact with the patient. It's everybody in the healthcare enterprise that has to be on board and involved in the workflow. You have to figure out what are your service goals. Is it provider-to-provider encounters, provider-to-patient encounters, and what type of model are you going to be using? And then where are you connecting to? Are you connecting to another provider's office, to a large metropolitan hospital, an academic medical center, a specialty telemedicine clinic, or are you going straight into the patient's home? All of these different models are going to have different workflows, different reimbursement structures, and different ways of interacting with the people on the other side. Now, like I said before, Arizona is one of the best states in the country, in my opinion, that is very amenable to and supportive of telehealth. And this was a bill that was passed last year, signed by Governor HB 2454, and there's a fact sheet that you can download that kind of explains what it's all about. But basically, it's one of the most liberal and supportive telehealth policies in the country. For example, it does not, it prohibits insurers and so forth from limiting or denying coverage through telehealth and for ancillary services. It does allow for audio-only phone encounters when you have an existing relationship under certain circumstances. And this is really good because there are some communities out there and some people who all they have is If they can't connect up by a phone, you know, they may not have computers or laptops or access to broadband to do a video. So they may only have audio. And trust me, audio in many circumstances is better than nothing. And you can see there's a lot of other things that have allowed and permitted during COVID, and these extend far after. For example, it allows physical and mental health status exams to be conducted during telehealth encounter. It allows for parity of services, it allows for parity of reimbursement, and all sorts of stuff. So it really is quite amenable to telehealth being conducted within the state of Arizona. Now, on the federal level, there were a lot of waivers that were put into place at the CMS level with Medicare and a lot of other restrictions that used to be in place prior to COVID were kind of waived during COVID. Now, unfortunately, the public health emergency is pretty much ending at the end of this month, and a lot of these waivers are going to expire. So, for example, waivers that allow for not paying as much attention to HIPAA as we used to, and being able to use non-HIPAA compliant platforms like Zoom or like Teams that may not be HIPAA compliant, or crossing state lines for providers to be able to provide telehealth. So on the federal level, it looks like the majority of these are actually going to expire, which is a shame, but we do have people in Congress who are fighting to try to extend them or make them permanent. But the ones that are here in Arizona because of HB 2454, those are in place and hopefully will remain in place no matter what whoever's in charge in the state. The Governor Busey is a really good governor who really gets it and the importance of telehealth. Now, what does it take to provide telemedicine? Well, it takes some experience. It takes some training. You can't just kind of hop on a video and hope to have the best encounter ever. And actually, the AANC, the American Association of Medical Colleges, came up with a set of telehealth competencies that they expect providers to have. And they're freely downloadable from the AANC store, or you can just ask me. I have a bunch of copies. I can email them to you. But it defines 6 domain areas where people should be competent in or show skills, demonstrate skills that they can do telemedicine. And to some extent, they're, when you look at them, they seem pretty common sense. Patient safety and appropriate use of telemedicine care, data collection and assessment via telehealth. How do you do a physical exam via telehealth? Communication via telehealth. It's different to communicate with somebody via Zoom or to connect with somebody in the patient portal and email back and forth than it is to sit in the office and talk to them face to face. You should understand the ethical and the legal requirements for telehealth if you're going to practice it. You do that for traditional medicine now. Most providers understand at least what's legal and what's not. You should do the same thing for telemedicine. You don't have to be an engineer, but you should understand a bit about the technology for telehealth. And you should understand about access and equity in telehealth and how do you kind of promote that across different types of populations and patients. This is just one example, and what it shows is that these skills develop over time, and they expect you to have different skills at different times. So as you're coming out of medical school and entering residency, you should have some skills. As you then go from residency into practice, those skills should be more honed and more sophisticated. And then when you're out there in practice, you should have even more developed skills, and you should be able to, for example, serve as a role model to other people. And this is just an example of one of the domains. This is communication. And you can see how it has 3 different tasks or 3 different skills that they expect providers to have and how they change across time as you gain experience as a provider and you get out there in the world practicing telehealth. This is another good guide, and all of these resources that I'm talking about are freely available through us at the Southwest Telehealth Resource Center. But telehealth and medicine in general, you really have to have cultural awareness and cultural competencies. And this is a great guide. It's called the Culture Guide. It was for American Indian and Alaska Natives. But I really think the topics that they talk about and the skills they expect people to have are cross-cutting across any culture that's different from our own. And you can see it kind of talks about myths and facts, tribal sovereignty, cultural customs, spirituality, things that people really should be aware of when they're dealing with patients from cultures that aren't their own. The role of veterans and elders, what is cultural identity, historical distrust, and so on. Again, really great document that helps in telemedicine encounters, especially with folks around Arizona who come from such varied backgrounds. There's also a lot of guides and examples and templates. This one, for example, is how to conduct a telehealth physical exam. It goes through all of the relevant systems that you would normally have your physician check you on: your eyes, your respiratory system, your heart, your abdomen, musculoskeletal, psychiatric. And how does somebody do that in a virtual encounter as opposed to doing it in person? When you can't, tap somebody's side or feel their side to see if their, appendix, for example, is tight or something. So there's a lot of really good resources out there and things that people have thought of to help people do telemedicine. This is also from the same group on how to adapt your annual wellness visit to telehealth. This one goes through everything from the beginning and kind of what are the codes that you can use to get reimbursed, all the way through, getting the family history, how to screen for depression, how to screen for balance, gait, and wrist fall. And how do you do that in a virtual encounter? This really nicely goes through and explains how to do all of that. And then it explains how to close the visit and how do you tell the patient what to do next, what are the expectations in terms of what you're going to do for them, like send out a prescription, or what you expect them to do. Continue certain rehab exercises, for example. A lot of resources, like I said. The American Medical Association came out very quickly in COVID with a telehealth implementation playbook. The American Telemedicine Association has a number of quick guides as well as practice guidelines for a number of clinical specialties. And again, we have all of those, so if you're interested, just let us know. We have a lot of fact sheets, tips, videos, all sorts of stuff for not only providers but patients. And every professional society by now has some kind of statement or stamps or tips, helps, and guides to get people through telemedicine and how to do it. We have, as part of the Arizona Telemedicine Program, created something called a Service Provider Directory. So if you don't have the resources to do telemedicine, but perhaps you have funds and you want to do telemedicine, but you're going to work with a company that not only provides a telemedicine platform, but also provides the providers to help cover your services. This is a really great tool. All you have to do is look at, it's a drop-down menu, so you pick your state, what type of service you're interested in, who are your customers, are they educational institution, FQHCs, and then maybe what ancillary services you want, and then just search for listings. And we have found a lot of companies that provide these services. Those companies will come up. We don't endorse them in any way. We simply provide the information, and you can then follow up and do your due diligence in potentially picking a service provider to work with your institution and your patients. We really, really recommend those are the websites that you can access the directory at. We really encourage providers of all backgrounds, as well as other people within your healthcare enterprise, to get some training about telemedicine, what it's all about. And we do offer 2 tracks. These are full-day tracks. One is on developing a telemedicine program. Talks about clinical services and sort of a broad overview of telecommunication infrastructure, the business aspects, and so on. And then track 2 gets more into the clinical telemedicine applications. For example, peds, telepsychiatry, teleradiology, occupational therapy, and so on. These are completely free to people in Arizona, New Mexico, Colorado, Nevada, and the Four Corners region. That's the area that the Southwest Telehealth Resource Center covers. We also can do customized training as well, depending on how much you want and where, if you need us to travel, there might be a possible cost associated with it. But getting the training and getting out there really does help prepare you to engage in a telehealth encounter. As I said, we are the Southwest Telehealth Resource Center. Our catchment area is Arizona, New Mexico, Colorado, Nevada, and sort of this Four Corners geographic region. There are 12 CRCs total. We are just one of 12 that cover the entire United States. There's also 2 national ones, CCHP, which covers anything and everything you ever wanted to know about policy at the federal and each individual state level. And then there's TTAC, which is the Technology Telehealth Resource Center. So all of those are available. We rely heavily and collaborate with them extensively to provide services across, to everybody across the United States. This is our webpage, and as you can see, we have a lot of resources available. There's a direct connection to the service provider directory. We host a lot of webinars and other types of events, very educational and all for free. We have an online library of materials. We have a ton of resources, fact sheets, information. We try to keep it as updated as possible. We have a blog, which is just fun reading and a lot of telehealth related topics from a lot of our experts and ways to contact us. This is just an example of some of the forms that we have created and templates that are out there. These are informational sheets, and we have translated them into a lot of different languages, but these are most relevant for Arizona. We translated them into Navajo and into Spanish. Some of these are provider-oriented, and some of these are for patients to teach them about what telehealth is all about. And again, totally free resources for those in our catchment area. So basically, telemedicine technology should not be a barrier to anybody. And speaking of technology, again, Arizona is really ahead of the game there as well. We have a very dedicated Broadband Commission that is trying to get broadband out to as many places as possible. They took advantage of recent funds made available by the FCC in a number of rounds of COVID funding, and they really are getting COVID out there, getting broadband out there to the communities who really need it. So we are reducing those barriers of technology. There's a lot of tools that can help facilitate, even enhance the encounters people have with patients to get at their health status. It does, however, create a very different workflow than we're used to as providers and as patients. And the devices that we have to interact with are different. So it does take some training and experience with those in order to make these encounters effective and efficient. As I've definitely shown you, hopefully, there's a lot of resources with tips, with methods, protocols, all sorts of stuff that you need to get telemedicine out there into your community. So thank you very much. This is my email and our Twitter accounts, and we can open it up for questions.
Okay, thank you very much. Does anybody have any questions? Nancy, go ahead.
Am I on?
You're on. You're on.
You mentioned very quickly in that wonderful presentation, by the way, service provider directory. Where would I find one of those service provider directories?
That is on our Arizona Telemedicine Program website, and it is also on the Southwest Telehealth Resource Center website.
And is it?
So if you want to Google, just go Google Arizona Telemedicine Program. That'll get you right to our website, and it's right there, and it's one of the big buttons.
I'll also send a direct link to Denise, and she can disseminate it.
I didn't hear that.
You could put it in the chat too.
I'm sorry, is there someone speaking on the telephone?
Zoom, but Teams has a chat too. Chris will put it in our chat.
Can I interrupt and ask who is speaking?
Oh, that was Chris Stewart. She's my colleague at the Arizona Telemedicine Program. She's the current director of the Arizona Telemedicine Program.
Okay, thank you very much. Any other questions or comments?
Just to part B, the service provider directory, is it geographically, or is it the entire state of Arizona, or is it the entire geographic area that you folks cover?
The entire geographic area plus the whole United States. So literally, you can go down and pick your state of interest, and we have all 50 states there, And if a company is providing services in Arizona, it will come up in your search. If they don't provide services in Arizona, it won't come up in your search.
Does the service provider directory deal with the competency
No.
of the service provider?
It's a list of companies that have services. So they have typically a platform, sort of like Teams or like Zoom, except dedicated to telemedicine. And then they have a series of clinicians usually that they have on staff that can provide telemedicine services instead of your physicians. If you, if you bring them on board. So for example, if you don't have a neurologist, you could go to the service provider directory, see which companies have neurologists that are licensed and credentialed in the state of Arizona, and that company will come up, and you could then negotiate with the company for services so your patients can have access to a neurologist.
Thank you.
I have a question. Can you provide these services to someone that does not have access to internet?
You can in different ways. One is you can do, at least in the state of Arizona, you can do audio only. So if they have access to a phone, they can get audio only, and there are a lot of things you can do for a patient over the phone. There's also a lot of communities that are, for example, in community centers, in libraries, mobile vans, different types of organizations are creating spaces that have access to internet and are creating spaces where patients can come and utilize that space and the technology there in order to access providers.
Okay, I know there's a lot of talk in Arizona about broadband is being expanded to the rural areas, but the state of Arizona kind of looks at the Kingman area as rural and underserved. But in Kingman, we look at little communities like Dolan Springs and Meadview and White Hills and Chloride. There's just a number of communities that they don't even have very good dial-up service. I mean, so when you think of broadband coming to Arizona, it's not yet coming to all the really small communities where telemedicine becomes critical because of the distance to travel to see a regular provider. So I just wanted to throw that out to you. You know, broadband is.
Yeah, it's going to take time. You know, it does take effort. You have to put the towers up and get the telecom companies to do all this. And it takes an investment. But like I said, I think Arizona is actually farther ahead than a lot of the other states in that respect.
Okay, good to know.
Not there yet, but farther ahead.
Okay, anyone else have any comments?
Yes,
Alan?
Supervisor Bishop. A quick question about what type of partnerships have you seen? So you say we can bring these to our community. Are these through, do we connect you to our hospital services, or what are the best practices that you might have seen throughout the state where we can use some of these telemedicine services and connect up so that the residents of our communities have access and can actually get to these services?
There's an awful lot of telemedicine already going on within the state, and you know, you'd be surprised how many hospitals are probably doing it that you don't even know about that they're doing it. A lot in northern Arizona, a lot in southern Arizona, and not just in the Phoenix, Tucson, and Flagstaff areas. I mean, really out there in a lot of the communities. You know, the easiest way to find out what's going on is to talk with your local hospitals. The partnerships that are being developed are widespread. We, for example, have two organizations, the Northern Arizona Telemedicine Association and Southern Arizona at Telehealth Alliance, and they meet on a regular basis. And these are various providers of telemedicine from the northern region and the southern region that get together on a monthly basis and talk about what's going on in the region, how they can collaborate with each other. The libraries are very much getting involved in, for example, helping customers get access to the FCC funds that were made available to patients in order to get access to devices and get discounts on their telecom services. So there's an awful lot going on a lot of the native areas. They are actively seeking grants, as are a lot of communities. Summit Healthcare started their whole telemedicine program by working with us initially. They applied for a federal grant. We helped them with letters of support, some of their training and so on. They were able to get a grant, and then they parlayed that into more and more and got their, whole enterprise really hooked on telemedicine, and it grew dramatically from there.
So when you say they, who's they that went and got the grant?
Summit Healthcare.
So the best practice is I go find a provider, whether that's a hospital or a health group, that then I connect them into this network where then they can bring in, we have issues with behavior health, the urology, pediatricians. We have specific areas that we need. And so then I would have them reach out to you to create this network so that our citizens have access?
I'm not sure what you mean by network, but we help facilitate the connections between providers or, healthcare organizations and communities that may or may not need their services.
Okay. What's the next phone call I make to make it happen?
And I think that Arizona is great for telemedicine. However, I think the distribution is still not equally distributed, especially in the northwest corner of Arizona. There's a lot lacking in the support. And I know, like you said, the institution, the physician had to reach out. I went down to ASU and attended a meeting, and that's why I asked to go help to have this meeting, is how bring the technology here to the county. And as a physician, for example, two things you mentioned briefly, I just want to say here. For example, the telephone visit. I see my patient for the past 5 years, for example, in the pandemic. We did not follow it, like you said, even the phone call visit better than nothing. And it was not allowed because I think that was the misunderstanding with the law and rule regarding HIPAA, regarding reimbursement. So that's what the institution level is very lacking. And I got the information here. I want to reach out to my administration and ask them to see if they can get, knowledge regarding the system that we have. And he said Arizona is great for telemedicine. We should have that. And we did not have that during the pandemic and the future. We should. HIPAA, worry about HIPAA, so people really worry about HIPAA, we shut down. I think as clinician, we should have a sign in front of the office. Any office should say, we will offer tele-ICU if you ask for us. That should be even law, just like we have that later for you. Similar process. We don't have that. Right now, it's just up to the individual. You get a patient here, if they ask for tele-ICU, that's kind of a violation of some sort of law. You see what my point? And then I really wish you have the statistics of who attending the meeting and distribution resources. Because I don't see a whole lot up here in northwest Arizona. I don't lack a fairly strong person because leadership that sees the vision, they have that. I just want to see.
I know exactly what you're saying, and I agree 100%. And a lot of it has to do with, again, somebody from, one of your institutions, for example, reaching out to us and saying, okay, teach us about telemedicine and tell us what it would take and help us make it happen here. We can help in terms of, making recommendations about the types of technologies, what different specialties would require, what kind of training and so on. But it requires a commitment on the part of your institution to make that investment into, the technology, into training its people, training the billers on how to bill for the telemedicine encounter and things like that. So it really is something that everybody has to say, okay, we're going to really do this and make it happen. And it's funny,
I really hope.
5 years ago,
Right, I really hope. Yeah, I really hope that the meeting, I have your contact information, I will use that and then let my administrator know. And I hope any member on the board have any affiliation with the healthcare facility, please help the community.
Okay, thank you. Anyone else? Yeah, Mr. Manley.
This is Hunter. I have one quick question, if I may. You mentioned a lot of the rules and guidance are going to potential, all the waivers may expire at the end of this month. Where's the best way to stay up to date on that, especially with regards to, clinicians that may be outside of the state of Arizona? I love the directory. That's going to be a great service, to make sure that the providers are credentialed and everything, because each state has their own licensing board and regulatory board. It's so difficult to keep up with it because with telehealth, you may have a patient and a clinician in different states, and that can be perceived as high risk, and we definitely don't want non-Arizona licensed clinicians to necessarily do that care. So where's the best way to stay up to date with all the changes?
Yeah, two ways. One is the TRC that I talked about, the Center for Connected Health Policy, CCHP, and they update things on a regular basis. They send us a regular monthly update, and so you can reach out to them, or you can reach out directly to us with a specific question, and we can get that to you. So those are the two best ways.
Thank you.
I'd love to say the federal government updates their websites on a regular basis, but I just can't say that.
Go ahead, Kurt.
So how do I get a copy of your presentation so I can use it for reference and so that I can present it to my practice? Now, my practice is involved with 8 clinics throughout Arizona. So this from anywhere from Sierra Vista to Yuma to Prescott to here. So I can get this information to my boss so that I can get that, so we can get more training for the providers. How do I get a copy of your presentation tonight?
You can email me, or if there's a specific contact on your site, I can mail it to them, whoever's our main contact, and I can email it to her, and then she can just email it to all of you, or you can contact Chris. Her email is in the chat, and I can put mine there as well.
Thank you.
Okay, thank you very much for that very informative presentation, and something that we're all interested in. I think we need to go on now, though, to the next item, number 4 on the agenda, and that's vector control education. Take it away.
Okay, so my name is Ron Balsamo. I'm the Environmental Health Manager in Mohave County Department of Public Health. And what I'd like to do this evening is just very briefly discuss the Environmental Health Vector Control Nuisance Abatement Program. Now, those of you who have been on the board and who paid attention to the board over the last few years may recall that in 2019, I gave a similar discussion on vector control nuisance abatement, and I just want to assure you that it's going to be much less scientific-y tonight and more about the overall program and what we've managed to accomplish in the last 3 years and what our challenges are moving forward. And so to begin with, the vector control and nuisance abatement has always been a pretty small part of what environmental health does in the county. However, I think the impact, at least from a public perspective, is fairly large when you think about trash and sewage control and pest abatement. And so one of the major things that has occurred in the last 3 years is that we've had a realignment within the county with regards to the nuisance abatement part, of public health. Basically, the majority of the trash and the sewage complaints were consolidated under developmental services. And that was thanks to the Board of Supervisors spearheaded by Supervisor Bishop, and that was really fantastic because you basically went from sending 3 or 4 inspectors and different notices of violations down to, one house, one place of business. However, what we didn't anticipate at the time when we were in discussions about that was developmental services really isn't designed to deal with anything that actually moves around and is alive. And so all of the others, the birds, the bats, the bugs, the rodents, things like that, we still retained. And so what I've been striving to do is to bring that aspect of public health under the control of our vector program. And so I figured it would be useful to remind everyone, when I talk about nuisance abatement versus vector and disease vector, species, what am I really talking about? So a nuisance species, you can think of, causing a nuisance. It could be like caddisflies in Bullhead City at certain times a year. It can get extremely annoying, right? Can be bitey, stingy things like mosquitoes and bees and things like that. However, if you are bothered by a nuisance species, you're not going to catch a disease, is the point, all right? So for a nuisance species, it's something that causes a public health nuisance, all right? When we're talking about disease vectors, which, by the way, also include mosquitoes, so some mosquitoes can be a nuisance species and others can be vector species. Flies, pigeons, these are organisms that potentially carry diseases that adversely affect human or livestock health. Okay, so environmental health, we address both as public health hazards. And I can say in the last 3 years, the lion's share of our efforts have been on mosquitoes. And so that's what I'm going to basically focus on for, the next 5 minutes or so. So why care about mosquitoes? Well, believe it or not, if you ask the average person, what animal do you think kills more human beings every year than any other? Hardly anybody considers insects at all, right? They'll say, oh, maybe tigers or elephants or monkeys or something, right? But actually, mosquitoes are responsible for more deaths on a global scale than any other organism on this planet, with, of course, the exception of other humans. But over 750,000 people last year died from mosquitoes, right? So there are about 3,000 or so species of mosquitoes. About 600 of those are vectors, all right? So they have the potential of carrying disease. We have about 40 plus, 41, 42 species that are reasonably common in Arizona. And of those, about 12 to 15 are vector species. And in Mohave County, we typically encounter between 7 to 12 species in a season. And I'll get into that in a little more detail in a minute. But the bottom line is, why do we bother with mosquitoes? Is because we want to know who's in the neighborhood, because mosquitoes can kill people, And so, I also get quite often, like, oh, well, you're in the desert. Why do you care about mosquitoes? And actually, we have a big river that borders Nevada and California, which is a great place for mosquitoes. We have marshes behind that. And then on top of that, people don't realize it, but mosquitoes, different species of mosquitoes can live just about anywhere where there's some water. So if there's culverts that go underneath a road, tires, buckets, holes in trees, anytime after a rainfall, all right, a typical female mosquito who is fed on either a human or an animal can lay over 200 eggs in a week. Egg to egg typically is 8 to 10 days, but the floodwater mosquitoes that we have in Mohave County, they can go egg to egg in less than 7 days. So they're overachievers. And we can literally go from one mosquito to over 200 million in a single month. So, we really do have to pay attention to what the mosquitoes do in our county on a yearly basis. The more we look for potential vector species, the more we're finding. 3 years ago, when I talked about what the program traditionally was accomplishing, it was primarily controlling the floodwater species in Mohave Valley, Fort Mohave, Willow Valley. And so we started expanding that effort to try to see what else was out there. And to this day, most of the monitoring and spraying is still Fort Mohave, Mohave Valley, because that's where most of the floodwater species are. However, some of the specific efforts that we've taken is to introduce larvicide or juvenile insecticides early in the season in these areas. And as a result of that, year over year, that's the YOY. I know I was asked about that already. It's kind of a financial thing. But year over year, 2018 to 2021, we've gone from millions, literally millions in our traps, all right, to hundreds of thousands. Now, of course, that's still far too many, and we still get phone calls, we get complaints, but we're making significant progress on the nuisance species of mosquitoes. The potential disease vector mosquitoes, and specifically now I'm going to talk about a genus Culex, right? Because Culex, it potentially carries West Nile virus as well as St. Louis encephalitis. And year over year, from 2018 to 2021, it's doubled every year, the numbers that we've collected in our traps. So we've gone from hundreds, right, of samples per year to test to literally thousands. Right, so for what it's worth, like I said, the more we look, the more we find. So what I have here are two slides, well, actually two maps. On the left-hand side, the yellow blocked out areas are where we receive over 50% of our complaint calls every year. Okay, and so this is Mohave Valley and Arizona Village. Right, it's an agricultural area where it's interspersed or checkered with neighborhoods. And the number of complaints that we get is strongly correlated to what they happen to be growing that year. So, and if I had pushed this back, 6 years, you'd see that we also had a lot more complaints further to the north in Fort Mohave. However, in the last, I'd say 5 years from before I was hired until the present day, we've developed a very strong relationship with the Fort Mohave Indian tribe, and we also have been collaborating fairly well with Bullhead City Pest Abatement. And so we've managed to get that whole region under control to the point where, at least from a complaint perspective, our numbers have gone down, along with the number of floodwater species we get on our traps. However, in the south, we're still mostly playing catch-up and fogging for adults. But, and that's fine. That's, just part of what we do. On the right-hand side is again, where I wanted to bring up the Culex again. If you look at the very bottom there, Lake Havasu, there's kind of a blue blob. And then in the middle, where Mohave Valley is, you see some green ones, and that's because the blue bled into the yellow, right? Primary colors and all that good stuff. And then up top, you see again in Bullhead some more blue. Those are not just, right, where we're finding Culex, but that's where we have found Culex that have tested positive for West Nile virus. All right, and so we've approximately tripled the number of traps that we have done, that we have conducted on an annual basis over the last 3 years, and we're doing our best to increase our presence along the river to see what's really, really there. And what we're finding is, there's a lot of Culex, and there's the more traps we set, the more positive culex we find with West Nile virus. So this is something that, if you don't do the monitoring, you would never see it and you wouldn't know it was there, right? And we did have 2 people in Bullhead last year, right, that tested positive for West Nile. One of them was believed to be from a local source. The other was from somewhere else, I believe out of state. But the way these things work is you see an increase in population of the organism, then you see the presence of the disease in the organism, and then you see the transmission of the disease to humans, right? And so I just want to make everyone aware downstream, and now that, that 2.5-year bolus where the pandemic occurred, and really that was our primary focus for everything, we get back to some sense of normalcy in our division and in our county. Overall, I want to make people aware that the West Nile is not going to go away unless the culex disappears, and I doubt that's going to happen. And I also want to point out that the abatement is very expensive, all right? Our costs range from a minimum of $900 to over $2,200 per treatment, and we typically do over a dozen treatments in the flood control areas, in a year. We receive about 200 complaints per year about mosquitoes. It's always about the floodwater species. No one is calling about a vector. Nobody calls me and says, hey, I've got Aedes aegypti in my backyard. It's all about there's this swarm of mosquitoes that are, chewing me up. And about a third of those complaints result in us going out to treat. So we'll get 6-7 phone calls. We'll validate it with a trap, and usually what that means with the floodwater is we get a sock full of mosquitoes, and still the vast majority of our complaints come from Fort Mohave, Mohave Valley. We're up to about 60% of our total budget for nuisance abatement of mosquitoes in Fort Mohave, Mohave Valley. And of course, we always treat an area where vector species are collected and test positive. So for example, in the Body Beach area in Lake Havasu, we contacted the state because the positive mosquitoes we actually collected on state land, even though I think it's leased to the city. But when we contacted the state and they said, oh, you're willing to do something about it? Fabulous. And they just said, go ahead and treat. So we did. And we were able to take care of that problem. But, again, I don't think it's going away. And we didn't have time, or resources at that time to, work our way down the river to see whether or not the culex was coming from further downriver near William Barr area where it gets kind of swampy, or whether it was further up to the north. And also I'll point out that when we do find culex in Fort Mohave, Mohave Valley, it's very difficult to actually find. I really give a lot of credit to my former vector control specialist, Kelly Pompas. If you can imagine having, a sock full of mosquitoes, and then maybe 100 of them are culex. The rest of them are Serophora or Aedes vixens. It's kind of like having a barrel of quarters and saying your job today is to find the 10 nickels in there and then test them. So, that's always going to be a challenge as long as we have those species. But at any rate, that's where we are today, and I think the program is pretty strong. We're doing a good job with the floodwater species in knocking them down. I think we're making everyone aware of the potential, for West Nile with the culex. I will point out that, Clark County gets a lot more positives with West Nile and also St. Louis encephalitis than we do. Riverside County and San Bernardino County also has more positives than we do. And 3 years ago, I told you we had like 2 positives in the whole year, and, now we have like a dozen. So it's, it's going to be an issue moving forward, I believe, unless there's some sort of a drastic change in the environment between now and next year, which I doubt. That's all I have, so thank you very much for your time, and I'd be happy to answer any questions that anyone has.
So Ron, I have a question. You collect these samples, a sock full. What do you do with them? Do you send them to a lab to be tested? Or does somebody put them under a microscope with a little tiny...
Yes, actually, it is with regards to West Nile in particular, because of the prevalence of QLEX, we bought the amplification kits, and we actually do the analysis in-house for West Nile virus. And so, yeah, we have someone sit down with a dissecting microscope, and they scooch by hundreds and hundreds and hundreds and hundreds of mosquitoes, and they pick out the ones that are QLEX, that are or any other potential vector, because that's not the only, vectors that we find. We do find Aedes, and we do find Anopheles and, other species that are potential vectors, but we just don't have the ability to test them. And, if we don't get positives and we don't get concern from our surrounding counties, at this point, we throw them in the freezer. But, it's because we're getting, positives in surrounding counties with regards to West Nile virus that, we made a decision to do the testing in-house, because we have no budget to, send every mosquito we find to Phoenix for testing.
Okay, well, I hope that person is being compensated well for doing that.
Well, yeah, I actually have to find a new one.
Don't look at me.
She left me, and she's going back to nursing school, which,
wonder
kudos
why.
to her. That's fantastic.
So, you talked about the mosquitoes, and we don't have many mosquitoes up in this part of the county, but we do have what's referred to as kissing bugs, and they're similar to a mosquito. They're a lot larger and easier to see, but they feed the same way as a mosquito. So do you have any information on the kissing bug?
Only that if you get a bunch of them, let us know. But yeah, they definitely are vectors, and they're seasonal. And luckily they don't really like to live indoors per se for long periods of time, but in our environment, you're likely to find them as much indoors as outdoors.
It's interesting. Several months ago, I have a little cabin. I opened the storage shed, and I thought it was a swarm of bees. There were so many of these kissing bugs inside, and they had all gone into this little tiny shed, and it was kind of frightening. I didn't, they were falling
refuge
from
and
the ceiling
resource.
and everywhere. It was just really.
Yeah, it really is. It's refuge and resource. A microhabitat where they're not too
That
hot.
happens again, do you want to be notified because of the large number that's there?
Yeah,
Before I declare war again on them?
That's data that I could use for sure.
Oh, you got it.
All right.
Close the door and call him.
I tell you, it was quite an experience. I'd never seen that many together in one space, and I was told that there must be some rodents in the area that attract them to that particular use. Okay, thank you. Does anyone have any other questions for Ron before he
Very good.
concludes?
Oh, thank you.
Thank you. I hope you find your new employee soon before the season really takes off.
So do I.
Okay, so let's go on to the communicable disease report.
So on the offhand chance you don't remember who I am, I'm Anna Scherzer, the epidemiologist here. And I must say my start in public health, at least my paid start in public health, was in vector control. And there is nothing quite like sorting through a pile of mosquitoes in front of you under a microscope. And what he did not mention is that the traps will also catch other insects and lots of dried pieces, parts, legs and heads and stuff that are very hard to sort through. It's not quite so easy. And if you sneeze into a plate of mosquitoes, you'll never forget the mess you end up with.
So how do you test them to confirm that they have a vector disease?
So when I did vector control, we were still waiting for West Nile virus to make its way across the country. It wasn't here yet, and that's why I was there. The testing, I never even got my hands into the testing, and so I don't know a whole lot about that. Ron's the guy to ask there.
Okay, I just wonder, I've been to autopsies before, and I know how that works.
Well,
but
it's
a
kind of like that,
mosquito?
but not quite so neat, because I think you take the mosquitoes and you squish them. You grind them up, right?
Oh, lovely.
Yeah, you grind them up and then take it from there.
Yeah, you make mosquito paste.
Mosquito paste. And you asked about kissing bugs. I can say a few things about kissing bugs as well. But before we get too far there, my job here is to give the communicable disease report. And the good news is that there's nothing exceptional or crazy or different or terribly noteworthy out there, aside from, of course, coronavirus. But the numbers that we've seen here, so just to orient yourself here, quarter 4, this is cumulative over all 4 quarters of 2021. We'll get through the first quarter of 2022 in a few weeks, but this just goes up through quarter 4 of the past 3 years. And the numbers for a lot of these reportable conditions are pretty comparable over the years. There are a few exceptions. A few things that I will point out is up toward the top, there's carbapenem-resistant Enterobacteriaceae. That, I think those numbers over the next few years are going to continue going up. That's a big fancy name, and it is a multi-drug resistant group of bacteria, not just one bacteria, but it's a group, it's a family of bacteria that are developing multi-drug resistance. And so it's on the radar, it's of concern, keeping an eye on things, and unfortunately, not just here, but in the state of Arizona, and I imagine elsewhere in the country too, the numbers of those reports are going up. So I think they're going to continue over the next few years. The influenza line there in the counts, you see, are crazy over those 3 years. I think the 2021 counts are just, I can't tell you how accurate those are or are not. There was just too much going on. I think influenza reporting fell off the radar. It would be nice to think that that's all the cases that we had reported truly for that year, but I don't think that that's the way. I don't think that's the truth of it. And then the other thing that I'll mention, since Dr. Wynn's on the phone, and of course our nursing manager is here, the tuberculosis down on the bottom, I'm glad to say that we don't have to talk a whole lot about tuberculosis over the years. It's a it can be a very time-intensive type of response for the nursing division. And because of the disease itself, you can end up with tuberculosis cases that move to Mohave County and still take a lot of our time and resources, even though they came here with their diagnosis. So the reason I point that out is if they came to us with their diagnosis, we don't get to count them. We only get to put those numbers on the sheet if they actually were a new diagnosis here. So that's one of the things, because I don't know that I've ever straightened that out for you or ever really made note of that. These cases and these counts that you see in front of you, 2 things. Number 1, they don't necessarily align completely with diagnostics. These are based upon Arizona state, they call them epidemiological case definitions. So it's kind of a checklist of things that we need. It usually includes lab tests and clinical signs and symptoms, those types of things. Those are things that we need at the health department to epidemiologically call that a confirmed or probable case. And so if you think back to COVID, if you've paid attention to some of those reports, some places report confirmed cases, some report confirmed and probable. The difference there, if you've ever followed any of that, what makes it a confirmed case is that they have a PCR positive test. It doesn't really matter what that test is, but that's what makes us count it as a confirmed case. Whereas if they have an antigen test and it's positive, again, it doesn't really matter, but that difference, if it's an antigen test, it only rises to a probable case. So that's at work with all of these case definitions. is what meets our criteria, which might not always assign as a practicing physician, you can give your diagnoses and you can treat according to your training and what you should be doing. And it doesn't always match up and align perfectly with the boxes we need checked off to call them this or that case. So that's kind of at play there in the background. And so tuberculosis here, Dr. Wynn might recognize that there have been some cases over the past few years, but we didn't get to count them because they came to us with their diagnosis. And so I just wanted to make note of that. You see some of the vector diseases in there, chikungunya up at the top. That was a big thing as it was showing up in Arizona, and we've had cases in Mohave County in the past. Malaria, the only one that comes up there is in 2019, and that was imported. I can't even remember at this point where that person imported it from, but it wasn't in this country. Brought it home with them from, oh, I do remember, I think it was New Guinea. And then West Nile virus is down there, and Zika is down there as well. And if you were listening carefully to Ron, he said last year there were 2 cases. Well, there were 2 cases. However, the other thing that doesn't show up here, we only get to count them if they're a resident of Mohave County. So the second person, it was decided throughout the investigation that the nurses did, they were going to be passed off to a different state. So originally it looked like they were our case, and we needed to respond accordingly. In the end, we didn't get to keep that count because it moved to the state where they were living. On the back, I believe I put just a summary of what we're seeing in terms of influenza this present influenza respiratory illness season. And again, I don't know how sure I can say these numbers are or how definite what's going on here. You do see that numbers definitely started rising, and there's no question there, and there's a big jump mid-February, I'd say. And we're still getting plenty of cases coming in and coming as reports. What you need to notice there in that picture is that those reports are generally coming from one facility, which is fine at this point because other facilities are busy doing other things. But recognize that it's mostly one facility that is showing up there. And it is a little bit unique that we're peaking, or hopefully peaking. I hope it's going to come down the other end this late in the season, if that is a true representation of what's happening. But I will say that there have been past years when we've had a peak of influenza, definitely not in a pandemic of any sort, where we've had peaks of influenza late in the season like this. So I don't know at this point what this means definitively, but it has happened before, if that truly is what's happening. What is unique with influenza, doesn't show up there anywhere on your paper, is the number of cases, the proportion of cases and their ages. So you think about influenza reports and case counts and the older folks, that's not what we're seeing now. In fact, in 5-year average, if you look at the past 5 years, the proportion of influenza reports that come to us, almost a third of them are usually folks 65 and older. What we see now on your paper doesn't show up, but what's on that paper, less than 10% of those cases that you're seeing there are for folks 65 and older. Lots and lots of children are in that report. About half of those cases that you see in that graph there are children. And there's a real big chunk here, which is really unique for the 19 to 49-year-olds. So there might be reasons for that. It doesn't necessarily mean that influenza is hitting those folks hardest now. It might just be we're being driven to get tested because of COVID in the background. Maybe we're just getting driven to get tested. And when we show up, some of these providers are using tests that test both for COVID and influenza. So in past years, I might not have even gone to the doctor to get tested. On top of that, right now when they're testing for influenza and COVID. So you might be more likely to have an influenza show up there. So we'll see if that's important, if that's significant. I don't know, but it is something that's a little bit different. And Kissing bugs. I will tell you that we had a situation, I think it was a year ago. If it wasn't a year ago, it was 2 years ago. Some folks, 2 different places. One was out by Yucca and one was actually down on Lake Havasu. One of the groups was finding kissing bugs around their home, around their trailer, and the other felt that she had been bitten by a kissing bug while she was asleep. You can actually collect kissing bugs, and we could submit them to the CDC. Number one, they will confirm that they are kissing bugs, and they can identify the species, which is a big deal. And they can also test for Chagas. That's the disease that you're concerned with the kissing bugs, the Chagas disease. So that is something that can be done. And the interesting thing about kissing bugs, which is interesting to me, maybe not so much to you, but the way that they transmit disease is through their fecal matter. So it's not the bite that's the problem. It's the problem that if you get bit and then you wake up in the middle of the night and scratch or rub the spot, then you can rub the fecal matter into that open wound. And that's how you get infected. It has nothing to do with the bite itself. The good news about that is that some species actually don't defecate while they're feeding. It's completely separate. Those are the bugs that have been identified in Mohave County so far. So you get bit, the bug leaves and defecates elsewhere, and what that translates to you and me is we're not going to rub it into the wound. So that's the good news.
Always a positive. Thank you.
Oh, it's good.
So I noticed on here Valley Fever.
Yes.
It went up in 2020 and then back down again in 2021. Is that notable or concernable?
I don't know how notable it is, and
Get a lot of
numbers like
questions
that.
about Valley Fever for people moving in here because we're famous for
That's right.
our dust.
That's right. That's right. And valley fever is what you call a very loose case definition. So going back to that checklist, the only thing you need on that checklist is a positive test. Almost any type of test. That's it. So it's very easy to get counted with valley fever. So those numbers, since they're so high, I don't know that there's a whole lot of meaning in 30 cases, 25 cases over the different years. I don't know how meaningful that is.
Okay, thank you. Does anyone have any questions of, you get off easy.
All right.
All right.
Thank you.
Thank you. Okay, we're going to go on to COVID treatment updates. Hello, Denise.
Hello. So just a couple of updates. One is, I'm sure you're aware that 2 of the monoclonal antibody treatments were paused because they were not effective with the against the Omicron variant. So there is still other options for monoclonal treatments available at various facilities. So we certainly recommend those treatments to folks if they find themselves positive and if they are compromised in any way or feel uncomfortable. So other than that, we don't have any other updates around COVID. We finally get to spend a little bit more time on some other topics, which is nice.
Okay, thank you, Denise. I think that pretty much concludes the business to come before the board.
Are there any other topics you would like discussed at the next meeting?
For the next agenda? Does anybody have anything they would like to have added? It doesn't look like they do, but I wanted to kind of make a nice announcement. I learned that the 48 Arizona Women Committee nominated and selected 2 Mohave County women, and since this is Women Making History Month, I thought I would make note of that. So this group recognizes outstanding women every 10 years for being remarkable, and they chose our very own Nancy Mongo and Crystal Burge, who we're all familiar with. So kudos to them. I just wanted to congratulate you publicly.
Thank you very much.
You're welcome. It's quite an honor.
And please congratulate Crystal for me. I haven't had a chance to see her. So if anybody does, please.
Okay, if there's no further business, this meeting is adjourned.